Thank you, Emily. Good morning, everyone. It is my great pleasure to introduce today's speaker, Dr. Dan Cortez. Dan is a pediatric cardiologist with additional subspecialty in electrophysiology. Dan completed his pediatric cardiology fellowship at Children's Hospital of Colorado and followed with 2 additional years of combined adult and pediatric electrophysiology fellowship at Penn State. Dan has also received training in adult congenital heart disease and is board certified in this area as well. He joined our program in 2018 and is currently the director of the Pediatric Electrophysiology program and also part of the adult congenital team. In addition to a very busy clinical practice, Dan has recently obtained a PhD at a very prestigious program at the University of Lund in Sweden on the topic of vectocardiography for diagnosis and risk stratification in populations at high risk for life-threatening arrhythmias. Dan is very productive on a research basis. And after only 2 years beyond fellowship, he has nearly 40 publications in high impact journals and is a sought after mentor by most trainees. His particular interest is in device-based therapies, including the first HIS bundle pacemaker series in pediatrics and implantation of the largest volume of leadless pacemakers in the United States. Both projects have not only greatly benefited our patients, but also our program in general and our reputation of the electrophysiology program in the country. Dan is truly a rising star, and he will present today the talk on pacing and defibrillation in pediatrics, the present and beyond. Take it away, Dan.
Thank you. Very, very kind words. Quite a bit, actually. So thank you very much. So today I'm going to, and also thank you for the opportunity to present. So today I'm going to be talking a little bit about pacemakers and defibrillators, and just sort of where we are with our current knowledge base, and also sort of what may be on the forefront and some of the things we've done here. And so today there's going to be a few learning points. I hope that the audience will develop a knowledge in pacing defibrillator indications in pediatric patients. Clearly, we won't go through all of those, but at least having some initial knowledge based on that. Also, an understanding of sort of typical pacemaker and defibrillator types. You know, I think we all sort of in our minds have an idea of what a pacemaker and defibrillator is, but there are a few different types, and I just want you to kind of know what to look out for around the hospital. Also have an understanding, including in that, of the newer types of pacemakers and defibrillators, which pediatric and adult congenital patients may stand to benefit from as well. So that'll be kind of what we'll get to in just a moment. But first, a little bit of history. So, the credit for the first external cardiac pacemaker is actually shared by a couple of docs. There's an Australian anesthesiologist, Mark Lidwell, and American physiologist, Albert Hyman. Working independently on sort of opposite sides of the world, they developed the first cardiac pacing machines. This was back sort of in the 1930s and 40s. And then eventually, Lidwell developed one that actually ran an alternating current, but required a needle to be inserted into the patient's ventricle. So in 1928, he used intermittent electrical stimulation of the heart to save the life of a child born in cardiac arrest. Essentially, he cardioverted a patient, a newborn, and then subsequently developed his device from there. But apparently, a child recovered and survived, but not a lot is known otherwise from Lidwell. He presented this at 1929 conference as well. So Hyman, just to give you an idea of sort of what his initial pacemaker looked like, or essentially electrical stimulator looked like, it was a hand-cranked device. And as you can see here, if you look sort of lower down, you see there's a wire that attaches to it, and then a needle would be inserted into the patient's chest. And you would crank the device to generate your voltage output. So clearly, we've come a little ways since 1932, but just to kind of give you an idea. Again, spring-wound hand-cranked motor, and he called it an artificial pacemaker. So that term's still in use today, but this is just to kind of give you an idea of sort of where this all came from. And then again, just showing the needles, really long needles that were used to penetrate the patient's chest in order to try to put these into the heart. So again, these are more electrical stimulators, although they use the term artificial pacemaker. Really, these are sort of invasive. Basically, clockwork drove this DC current generator whose impulses were directed in the patient's right atrium through bipolar needle, introduced into the intercostal space. So if you needed a Selfstarter for a dead man's heart, that's what this machine would do. And here you can see I'm in putting the needle into someone's chest, and sort of this is the an article that discussed sort of how he did it, and with sort of a slightly sort of newer device than the hand crank machine. And again, just sort of the next stage was really actually Paul Zoll developed an external pacemaker in 1951. So we still know Zoll from Zoll patches if you think of what we use to defibrillate people. Zoll patches sort of came from Paul Zoll back in the day. And so his external pacemaker had an electrocardiograph monitor and cardiac rhythm, and could generate an electrical pulse to pace the heart. It delivered electrical impulses with a 2 millisecond pulse width and 50 to 150 volts alternating current. For those of you that use pacemakers, you know 50 to 150 seems like quite a lot, but this is external pacing. So again, this is sort of outside of the chest, as though you were pacing with Zoll patches. And anyone that's done pacing with these sort of patches knows that patients don't tolerate it for a long time. So same thing happened back in 1951. Electrodes irritated the skin, and patients found it very painful to get electrical shocks on the outside of the heart. You may recognize this guy here, Erik Bakken, electrical engineer and TV repairman, was the co-founder of Medtronic and produced the first battery-operated wearable pacemaker. So we actually have a long history of collaborating with Medtronic here at University of Minnesota, and this is the gentleman that started Medtronic. I thought this was kind of a fun picture. This is actually Medtronic's first building. So I guess they've upgraded just a little bit since then. But you can see they sort of started really kind of in a garage, essentially, the first building. So here's a University of Minnesota physician, Dr. Lillahay, who back in 1957 was one of the leading cardiac surgeons in the country and was correcting heart defects while supporting the circulation. So one of the first people really, repairing people on so essentially a form of bypass. However, 1 in 10 patients that he operated on developed postoperative heart block. So this is still an entity we see sometimes now, but when you're doing a lot of surgery, especially, I mean, back in 1957, when a lot of these techniques were novel, really heart block was an issue. Postoperative heart block, putting patches in hearts, sort of, it's kind of like moving walls in a house where you have electrical systems in play. You may damage that electrical system, and this is really before a lot of mapping was known about exactly where the electrical conduction proceeded through the heart. So he and coworkers developed a myocardial wire capable of being inserted into the ventricular myocardium. And the first one was actually implanted on January 30th, 1957, in a 3-year-old girl who had tetralogy of Fallot and had heart block after that repair. Patient was successful. The little girl soon regained sinus rhythm and survived. Unfortunately, power outages, which were a lot more frequent back at that time, were a problem, and actually a child who was using one of these devices passed away due to the power outage. So after this neonate passed away, Bakken was asked to develop a better system. So here's what they came up with. So again, this is a wire. You can see wires that are inserted into the patient's chest, and through a very nice necklace that you can wear, you could have your external pacemaker that is battery generated. So battery generated power so that if a power outage happened, you could still receive your pacing. Here's, again, Dr. Lillahay with Bachman's pacemaker in a young child after heart surgery. Most patients had return of AV synchrony, and so basically this was a temporary pacemaker, and so they could take it out. One patient was paced for about 15 months, but one issue is actually recurrent heart block subsequently. So once they had return of their normal rhythm, there were still a lot of patients that had sort of later heart block that came back and then passed away. But this could at least get them through, the 1 in 10 patients through the initial postoperative stage. A first implantable pacemaker. So again, this is totally implantable. Don't have to wear it around your neck. This was actually performed in Stockholm, Sweden at Karolinska Hospital. The surgeon, Dr. Senning, some of us may be familiar with him from other procedures that were named after him. And then physician inventor Rune Elmquist, who actually trained at my PhD alma mater, Lund, they developed that. Arne Larsen was his first patient. He was having 20 to 30 Stokes-Adams attacks daily, and prognosis was very poor. So Stokes-Adams attacks are essentially where you lose complete conduction. You go asystolic. So 20 to 30 sort of asystolic attacks a day. His wife would have to resuscitate him. So his wife basically heard about projects these guys were working on and basically begged them to use this in, she would come show up daily and beg them to use this in her husband, who was actually also a national hockey player as well as an engineer. And so after enough showing up at their office over and over, they decided to proceed with it. At the time, Arne Larsen's treatment was maximized with ephedrine. They used pentamyl, atropine, isoproterenol, caffeine, digoxin, and whiskey. Looking through, I'm still not sure where the whiskey comes into play, but the rest are sort of other medications that we use, maybe not the digoxin, but isoproterenol is still a treatment we use to this day. So that was prior to the device implant. And then the first implantation occurred actually in the evening hours. They didn't want a lot of press around it, and occurred via left lateral thoracotomy. And the device lasted about 8 hours. In closing the pocket, they thought there may have been an issue with the generator, with the generator itself. So a second implantable pacemaker happened on October 9th, and that was in the same gentleman, and that one lasted over a week. This is actually Elmquist. So again, Elmquist and Senning were the physicians, but I apologize. This is Arne Larsen. He actually ended up outliving Dr. Elmquist or Senning, and he died at 86 years of age, unrelated to his pacemakers due to malignancy, after he had had 5 different lead systems, 22 pulse generators, and 11 different models of pulse generators. Here's him holding up the first generator with the wires cut. So let's talk about a case and how this sort of relates to pediatrics. So case number 1 is a 5-year-old female who had presented with Winky-Bach initially with no symptoms, Lyme titer and MRI negative, but the mother had a history of Sjogren's disease. And she presented in just Winky-Bach, which is where if you follow lead 2 here in the middle, you see there's a P wave, the little wave, then you see a QRS, the big wave. And the distance between those 2 waves gets progressively longer, and then she drops a beat. And so she was doing this quite a bit, was asymptomatic and otherwise doing well. So she was followed closely. By 8 years of age, she had progression to 3rd-degree B block and also had intermittent dizzy spells. So here you can see kind of had 2 P waves for every 1 QRS. And the P waves aren't necessarily at the same interval from the QRS. And the ventricular beats just sort of walk out on their own. So 3rd-degree heart block and symptomatic 3rd-degree heart block. So now the question is, well, what do you do? And in this common era, since we've gotten past wearable pacemakers on the outside of the body, where do we go from here? So pacemaker indications in pediatrics. So then again, I'm just going to talk about some of them because clearly there are more than this, but just to kind of give you an idea. Some of the main indications include advanced 2nd or 3rd-degree heart block in patients who are symptomatic or have dysfunction of their ventricles. If you have sinus node dysfunction and you have symptoms with it, and that you can clearly correlate to the sinus node dysfunction, then that's an indication for pacemaker. Postoperative advanced heart block, so either type 2 Mobitz 2-to-1 or third-degree heart block that's not expected to resolve, that persists for 7 days or longer. So our congenital heart disease patients, we start thinking about pacemakers at around 7 days. That is technically an indication, class 1 indication for placing a pacemaker. Congenital complete heart block. So when you're born with complete heart block or born with some degree of atrioventricular block that progresses to complete heart block, if your heart rate is below 50 after a year of age or below 55 within the first year of life, or you have any sort of ventricular dysfunction or again symptoms, then that's an indication. Unexplained syncope or passing out in a congenital heart disease patient with abnormal, with sort of a wide QRS who has fascicular block would be an indication. And in this particular patient, advanced second or third degree AV block with symptomatic bradycardia, given her intermittent dizzy spells that were not explained otherwise and sort of at rest, was the indication for placing a pacemaker in her. So once we get to the indication, the question is, what type of pacemaker should we place? Since pacing is indicated, what would be most appropriate? Well, our CT surgery colleagues are very excellent at placing epicardial devices. So that's always an option. But in a patient who's otherwise, who's big enough and who isn't necessarily undergoing, repair of their congenital heart disease, that may be a little extreme. So, really for her undergoing CT surgery or based on patient size, placing leads on the outside of the heart via thoracotomy or a sort of small subdiaphragmatic incision would be indicated. Transvenous devices, I typically will place these in patients that are 15 kilograms or larger, based on personal experience as well as sort of long-term data on those patients. And the problem with any of these pacemakers is, the classic way of placing them is to put a lead on the right atrium and a lead on the right ventricle and the apex. And if you look here at this X-ray, you'll see at the top right of the screen, or right of the X-ray, you'll see in the patient's below the left clavicle, you'll see the pacemaker device itself with sort of 2 ports and 2 leads in there. If you follow the leads along, number 1 goes into the right atrium, and number 2 goes into the right ventricle, sort of at the ventricular apex. And this was kind of the classic way of placing pacemakers. If they're on the outside of the heart, typically they're also, sort of in similar spots or wherever sort of access allows, but typically they're, sort of, on the right ventricular apex for the ventricular lead. Problem with that, though, is that 10 to 20% can develop what we call pacemaker-induced cardiomyopathy. So left ventricular dysfunction by placing leads, by pacing the heart from this sort of abnormal way. Now, other ways, well, what about a leadless pacemaker? I don't know if many of you have heard of those, but a leadless pacemaker, and by Medtronic, courtesy of Medtronic here, is this pacemaker that is sort of just about the size of a pill that has these little tines on it. This is the size in someone's hand compared to a pulse generator or sort of the pacemaker battery and computer here. And so would a leadless pacemaker be an option? These are things that have been out for the last few years now. And again, it's whenever a patient comes in, presenting for pacemaker implant, you always want to think, are they a candidate for leads, for leadless? What sort of would be the best, approach for them? And a leadless, here's a picture of when we implanted one through someone's left IJ into the right ventricle, sort of at the ventricular septum and the apical septum here. And this is the deployment device, and this is the pacemaker itself here. There's a temporary wire in here as well, and then some epicardial leads that had sort of burned out. This was a patient that had numerous epicardial leads, and just the leads kept failing every sort of 8 months to 2 years. So we placed a lead in this patient. The issue with, I guess the benefit of leadless is that there's no generator or transvenous leads required. So meaning there's nothing sort of stuck in the vein, so that's sort of a benefit. And the whole pacemaker is contained within this sort of little capsule pacemaker. That's the battery, that's the essentially the lead or the part that paces the ventricle. But again, there's no external wires that you need to remove, etc. The issue is that the whole thing itself is not easily removable. So really more suitable for transplanted patients, those with short lifespans, or those who may undergo CT surgery at some point so that you can replace the device. But again, nothing is external in these devices. So they're good for certain patients, but for our patient, and sorry, this is how the leadless looks inside the heart. You can see it looks like a little bullet inside the heart here. This is the whole pacemaker system, nothing else here. She has epicardial wires that were capped, but this is the actual device here, the bullet looking thing in the heart. And that's the whole thing. So the other thought process for this patient is, what about something called physiologic pacing? So what does that mean? Well, if you look at the picture of a heart here, and this is courtesy of a Jack article from 2017, there's a few ways that you can try to make the heart conduct in a more normal way to prevent or reverse pacemaker-induced cardiomyopathy. One would be through His bundle pacing. So if you look at this heart picture here, the right atrium is up here by the veins where the numbers are. The AV node is the kind of the big oval structure here, oval yellow structure. Right below the AV node, which again is sort of the normal pause button in the heart, right below that, the normal conduction goes to a bundle of wires called the bundle of His. And then that spreads to a left bundle and a right bundle. So you can actually pace the His bundle itself to have a more normal intrinsic conduction. And this, along with placing a lead through the coronary sinus to the left ventricle, or pacing the left ventricle externally, called cardiac resynchronization therapy, both of those have been shown to reverse and prevent pacemaker-induced cardiomyopathy. You can also just try to, you can also do what's called left bundle pacing. So again, notice that the big oval is the AV node. Below the AV node is the bundle of His. And then if you look at the left side of the heart, so the patient's left, you'll notice that there's a wire that can be screwed in to activate there, that you go through the septum. That's called left bundle pacing. So that's another way to help prevent pacemaker-induced cardiomyopathy and to actually reactivate kind of the left ventricle, as opposed to pacing from way sort of on the outside or from a different space in the right ventricle. So those are a few options. The question is physiologic pacing a possibility for this patient? So she ended up having a His bundle pacemaker implanted. It's a transvenous lead, but if you follow, so here you have the device, here you see there's still a lead in the atrium, and if you follow the second lead, it isn't quite as far out in the ventricle. It's actually just past the tricuspid valve, and it's engaging the His bundle. So again, this helps prevent cardiomyopathy from pacing, knowing that this small patient is going to pace for the rest of her life. And if 1 in 5 to 1 in 10 patients develop pacemaker-induced cardiomyopathy, and closer to 1 in 5 in pediatric patients, I always feel it's better to prevent it on the forefront, and especially if you can do it with 2 leads anyway. And if you look here, this is actually a printout from the pacemaker itself from checking the lead, and you can see there's kind of this little sharp deflection here. This is actually the His bundle that you can see on the pacemaker lead. So this is the right ventricular signal. Oh, I apologize. That's the right ventricular signal. Right before you can see a His bundle. And what this looks like when you see a patient in clinic, pacing is, so this is, if you notice this EKG on the left here, this is complete heart block. You see P waves kind of marching through. They're just kind of going at their own tune. And then the ventricle is just a junctional escape rhythm. So it's just coming from the middle of the heart, and it's just marching through at its own rate as well. But if you look to after pacing, now you have AV synchrony, and you have the P waves here, the ventricular signals following the P waves, but your QRS looks the same as it does over here. So we're engaging the His system. You still have a delay, sort of your PR interval is still longer, but you're actually pacing the His bundle, so you have normal ventricular conduction with pacing. And you can see there's just a little pacing spike here. So sometimes this can be a little confusing if you see the EKG like in the ER or something, but just know that His bundle pacing is, that could be His bundle pacing if you're seeing that you have 1-to-1 conduction and you see a tiny pacing spike, even if the QRS is the same as prior. So, there are numerous articles describing sort of how and in general that pacing can reverse heart failure induced by right ventricular pacing. Its left bundle can do the same. Cardiac resynchronization also can do that. And then we published an article here looking at his bundle and left bundle pacing in pediatrics, sort of describing our experience, including improving cardiomyopathy, improving patient's ejection fraction as well in a couple of patients by doing this. And since then, we've had numerous other patients and have found similar success that you can improve their ejection fraction and help normalize their squeeze by doing this. We also, in patients with congenital heart disease, this is also possible. You just have to sort of find the distal conduction and wherever the big kind of go around patches and such in the heart. We have a patient that had, an adult patient that had transposition of the great arteries and has something called a sending baffle, where essentially they connect, since the arteries are switched, they leave the right ventricle pumping blood to the aorta, but basically connect the atria over, so connect the left atrium to the right ventricle and vice versa for the other side. And so through that patient, we were able to engage from the LV side, actually. So from the left ventricle, engage the hip, but the left ventricle was a subpulmonic ventricle. Anyway, so you can do it in congenital heart disease patients as well. The other thing is, and I know this is going to look like a dinosaur, but this is, we can actually use three-dimensional mapping to minimize fluoroscopy and define the His bundle as well for this physiologic pacing. And so in this case, just to orient you, the picture here to the left is from the patient's sort of right anterior oblique view, and then from the right, this is from sort of a little superior to the patient and to the left and sort of in front. So if you think of the valve this way, so this is the right atrium, this is the right ventricle, this is the outflow tract of the right ventricle to the sort of pulmonary artery. And then if you think of the sort of connection, the tricuspid valve would be here, kind of where a lot of the color meets the meets sort of purplish blue. And then we found His bundle was actually a little inferior and posterior, so closer to the septum and inferior in this patient. This is a patient with AV canal defect, so their His bundle can be shifted. So you can use three-dimensional mapping to find it as well and to help minimize fluoroscopy. So we've been doing that quite a bit as well. So case number 2, patient with long QT syndrome. So we had an 8-year-old male with history of long QT type 8, something called Timothy syndrome, which is a very malignant form of long QT, and this QTc at times as well. And he presented after a syncopal episode. Syncope was for several minutes, unexplained, wasn't with sort of sitting up, standing up. It was while riding his bike at an onset, and he had amnesia for almost an hour afterward. He was already on nadolol therapy, which is sort of the mainstay for long QT treatment, and the medicine that is shown to prevent events better than any other. Significant family history also for sudden death in several relatives. Mother had aborted sudden death with VT at 15 years of age. Their cousin was sudden death at 8 years of age, several aunts and uncles as well. So definitely a malignant history here as well. So the question was, does he meet an indication for an internal cardiac defibrillator? And if so, what type do you place? So internal cardioverter defibrillators, indications, again, this is going to be a view of some of them, not all of them, but give you an idea. ICDs are indicated in pediatrics for those who are survivors of cardiac arrest due to ventricular fibrillation or unstable VT after you've excluded reversible causes. You find that a shunt is narrow and you fix the shunt, then they don't need necessarily an ICD if you think that's the cause. But if you have a patient who just presents and arrests and you don't have a reversible cause, then that would be an indication for an ICD. It's indicated for structural heart disease with spontaneous sustained ventricular tachycardia. And a heart disease with sustained ventricular tachycardia, they technically would meet an indication for an ICD. Patients with congenital heart disease with recurrent passing out or syncope of undetermined origin in the presence of either ventricular dysfunction or they're passing out, you can't explain it, you've excluded a bunch of causes and you take them to the electrophysiology lab and you put a catheter in their heart and attempt to induce ventricular tachycardia. If you can, then that would be an indication for an ICD. Recurrent syncope associated with complex congenital heart disease with advanced systemic ventricular dysfunction without a definable cause. So if you have someone who has congenital heart disease, tetralogy of Fallot, whatever it may be, with really poor ventricular dysfunction, and again, you don't have a definable cause for why they passed out, then they would also meet an indication for long QT patients on natal therapy with syncope of unknown origin. They would meet an indication for an ICD, as well as hypertrophic cardiomyopathy patients with first-degree relative with aborted or non-aborted sudden death. And hypertrophic cardiomyopathy, there's a few other indications. Septal or posterior wall thickness of 30 millimeters. There's a few others for them as well. But in regards to our patient that we're discussing, he meets an indication for ICD, met an indication for ICD based on the fact that he was already on therapy that was supposed to prevent VT, and he had syncope of unknown origin. So then the question is, well, what kind of defibrillators to replace? So a transvenous internal cardioverter defibrillator, this is a patient that had a right-sided implant, is basically a pulse generator connected to a wire that then goes into the heart. This is a single chamber one where it goes into the patient's right ventricle. And this coil, or sort of the more hyperlucent area, this larger area, this isn't where it actually delivers the shock from. Most ICDs are left-sided, but we tested this one. This patient was left-handed, so we wanted to go to the right. But this, lead extractions are an issue. You place an ICD lead in a patient, in a pediatric patient, I mean, you're going to have to keep an eye on that lead and remove it at some point in their lives and replace it, and et cetera. So those can be a little complex with thicker leads, and especially if you have, sometimes people will put a coil here in the superior vena cava, so that the way you can shock this patient out can be from a couple different ways. So you could shock between the two coils or between the coil and the pulse generator. And so, but those make it a little harder to extract, and you have risk of superior vena cava area tears. And these are good if someone needs pacing, or if they need what's called anti-tachycardia pacing, which is where you can actually use the device to pace someone out of a VT. Now, it doesn't work for ventricular fibrillation, of course, but it works if you have sort of a nice stable VT that you can pace yourself out of. So during no pacing indication, and that the patient's really more at risk for torsades, in long QT, we placed a subcutaneous ICD. You'll say, what the heck is that? Well, subcutaneous ICD is nice in that it avoids having to put anything into the vein. So this is an X-ray, an AP, and a lateral of the patient that we were just discussing with long QT8. And in this case, there's nothing going through his veins. This is all external. So this is all just subcutaneous on outside of the thorax here. And there's a coil that comes up. There's an electrode here. And there's the sort of pulse generator battery here. So this is placed a little more posterior in pediatric patients and kind of around their back. And this electrode kind of comes up here. The reason that there's a little bit of a bend to it is in a pediatric patient, you have to allow some room for growth. So basically you suture it at the bottom here and you suture over here, but this coil will straighten out as they grow. And since he's 8, he's gonna grow quite a bit. So this subcutaneous ICD is capable of delivering a shock only. It cannot pace you out of an arrhythmia. It can technically pace you for 30 seconds after the shock, but that's sort of painful external pacing, similar to that initial pacing device by Zoll. But in any case, it's a good option for someone who just needs a shock if they had VF, and to avoid having to put anything in the veins. And this wire should last the patient's lifetime. To change the battery out. So again, to go from some learning points that we discussed, wanted the audience to have developed the knowledge of pacing defibrillator indications in pediatric patients, have an understanding of typical pacemaker and defibrillator types like the transvenous types, and then to have an understanding of newer types of pacemakers like leadless pacemakers, physiologic pacing, so either cardiac resynchronization therapy or His bundle pacing or left bundle pacing, which can be used in adult and pediatric patients, and then subcutaneous ICDs as well. Just references, And I want to say thank you, and particularly Dr. Steinberger, Chief of Cardiology, Dr. Donegle as well, Chief of Pediatrics, Dr. Bass for support with approaching novel device implants. He did a lot of better device implants and novel, some years back, and was always very supportive. Even though he's not an EP, it wasn't bad advice from a cath doc. It was pretty good, actually. So, as well as Dr. Dunnigan, our senior electrophysiologist, and then our cardiology and CT surgery colleagues, of course, and our very teachable fellows. And of course, my supportive wife, who's also a cardiologist here, Nandita Sharma, and sweet daughter, Natalia. So thank you all. I'll open it up for questions at this time.
Feel free, if you have questions, you can go ahead and put them either in the chat or in the Q&A function. I would be curious just to hear a little bit about how you talk to families about these devices and kind of the informed consent process, especially when there's a sort of newer device that isn't as tested and there's an older one that might work decently, but the functionality is maybe not ideal in some ways.
Sure. So I'm very upfront with the families actually about sort of what's been studied, what where how much data we actually have on a lot of this. So for instance, we're in a couple of large registries. So for leadless pacing, we're in a large registry, so I have access to that data to be able to discuss how are people, what have been complications of it, what have people seen with that, and then also I'm very upfront about this is something that we cannot remove, and we don't know what that would look like 50, 60 years down the road. So if you don't have an indication to have it removed at some point, then then it may have to just be turned off. And we're not exactly sure what it'll do. So far, it seems like it'll be safe, but we just don't know. And then for physiologic pacing, also there's a lot of data on that. So I'm just sort of discuss that, here's what the adult data shows, here's what we've seen so far, and here's what we expect. And subcutaneous ICD, same thing. We're in a large registry and actually just had a paper published with the Pediatric Adult Congenital Electrophysiology Society on 17 or so patients who had subcutaneous ICD group, and sort of discuss what did they find, what were the possible complications. So I just try to be open about it, and I say, here are the risks associated with each, right? Nothing is perfect in life. No device is perfect, but I also discuss sort of why I think one might be better for another. So for instance, I think parents are very receptive when you discuss physiologic pacing versus putting a right ventricular apical lead, that 1 in 5 pediatric patients will develop dysfunction of their left ventricle from pacing. And when you put the numbers like that, I mean, your number needed to treat is 5. That it's really, I think parents get that as well. And if we can put the same leads, still have a 2-lead system, and prevent any complications down the road, I think parents are very open to that. So it's just a conversation. As all of my sort of nursing staff and MAs at the clinic know, I probably take way too long with patients, but definitely want to make sure they know exactly what we're capable of and exactly how much data we have on what we can do.
For what it's worth, I don't think it's possible to spend too long with patients. That's my 2 cents. So I'm sure they're grateful for your kindness and clear explanations. I know we've had a lot of students tuning in to Grand Rounds, and this is a little bit of a left field question, but you're obviously somebody who's developed a lot of expertise within cardiology and done graduate studies. Can you remember back to what got you interested in cardiology way back someday, and how you found the field of EP? It's your chance to recruit some new buddies for down the road.
Sure. So I actually, when I was about 6 years of age, five, 6, my grandmother had a cardiologist. I lived in Arkansas, who would do bedside calls. And I spent a lot of time with my grandparents, and they were sort of sick and had heart issues. And the cardiologist would come to your house at that time. So it's been a while, but and just sort of seeing the bedside manner, seeing someone that could explain something very intricate to patients who may not have had, the similar education as they did, I thought was amazing. So I actually wanted to be a cardiologist since I was in like preschool, but, and then I sort of fluctuated, maybe I'll be an astrophysicist or an astronaut, whatever. And eventually I came back to it. And after chemical engineering, went to med school, and I realized, I loved sort of plumbing and how all of that worked. And from a chemical engineering perspective, which was my undergrad, it was nice to see that in physiology. Although I missed the, integrals and Bernoulli's equation in a non-differential form is kind of sad, I think. So I really missed, being able to do all the equations with it, but I thought it was really cool and how that physiology affected people. And I also grew up with sort of my mom and brother were always in the hospitalized, had a lot of health issues. So sort of seeing how people interacted with that was nice, and people that could really explain something to you, I think was key. And in med school, the summer between my first and second year, I actually did a rotation at the Johnson Space Center. And I met a guy, Todd Slagle, who was the head of, he was an internal medicine doc, but he had developed enough knowledge in cardiology that he was running the cardiology division there, as well as the neurology division and the astronaut clinic. And he set me up with a project that looked at vector cardiography or three-dimensional EKG for trying to identify Chagas disease in patients from Venezuela. And I was born in Venezuela anyway. I lived there for a couple of years. And so I thought that was it was really cool to see how EKG or 3D EKG could affect that. And then from there on, I think I was pretty hooked, and then just did more and more projects. And of course, in cardiology, I loved EKGs and VCGs, and so it was kind of natural to go into electrophysiology, I felt. But I love the idea of being able to see more in an EKG than what's sort of reported, and be able to think through stuff. And then with devices too, EP is really nice because it's a hybrid of technology and patient care, and all of the advanced things you can do with a device, like determine heart failure based on a remote transmission from someone's pacemaker.
Thank you for sharing that. I think we don't talk about our origin stories enough, and that's a nice chance for us to get to know each other. And I know the students and residents always kind of love hearing how we got to where we are. Gail Brotman has a question. Do you use 3D mapping with electrophysiology?
So, Dr. Brotman, I do. So normally we use three-dimensional mapping, which is essentially you put patches on the patient and you can look at either tissue resistance or impedance changes or magnetic points, and sort of localize where your catheters are. So a lot of our ablations we do, I'd say more and more without any fluoroscopy, because the three-dimensional map lets us know where we are. So then we started using that for, there were a couple of sort of smaller studies, 30 adult patients, 15, et cetera, where they actually were trying to do that to do hip bundle pacing. I thought, wow, that's really great for those 80-year-olds, but what about for these kids who are going to have repeated radiation? So we've been doing that now here as well, and find that we can reduce fluoroscopy time to a 20th, 30th of what it was by using that along in conjunction with some fluoroscopy, of course, to do this hip bundle pacing as well. So actually trying to utilize that in a slightly different way. And there isn't really any pediatric data on that except some case reports here and there, but so there's not a lot of guidance, but I think we're figuring it out pretty well. We got a nice team that's in the lab to help us figure that out. So yes, I do.
Gail is revealing a audience member conflict of interest that her husband helped to develop 3D mapping catheter software. The company is called Endocardial Solutions. I don't know if we're giving them a shout out. I guess we are. So it sounds like she has some household experience of the 3D mapping.
Oh, I love it. I think that the next forefront will really be voltage mapping, and how does that compare to what you find on MRI? How does that compare to other things? Because in EP, we use that a lot as an idea of where are patches for congenital heart disease, where is the fibrosis? And you can look at endocardial as well as get an idea of epicardial scar as well based on that. But no one's really defined it enough to use it, really for diagnosis, et cetera. But no, I love 3D mapping. It's definitely an awesome advancement.
Great. right. Well, it looks like we don't have any other questions coming in the chat or in the Q&A, but just want to thank you for a really excellent talk. I loved the medical history. That's fascinating to think about those first patients with just like a needle sticking into their heart in a giant suitcase. That's wild.
Yeah. Thank you. Yeah, no, there was a picture of someone. There was one of the patients actually that you kept having to plug it in. So there's a video of them kind of walking through the halls, having to unplug it and put in another plug. Patient would pass out, and then they'd plug it in, and they'd wake back up. So I mean, it came from quite interesting origins. I'm glad we're past that at this stage.
Sounds like we've come a long way. Well, have a wonderful Wednesday, everyone, and we hope to see all of you here next week for our Gold-Headed Cane presentations and Julie Ross Awards. Thanks for being here.
Thank you very much.
Thank you.
Bye, everyone.